Hi, my name is JP Saleeby. I am a functional medicine and integrative doctor in South Carolina. I've also served on the LDN Research Trust Advisory Board for many years, and I am sorry I'm not able to join you in person in Portland, Oregon this year for the annual conference, but Linda had asked me to record my presentation for viewing later. So I'm going to be talking about neuroendocannabinoids and LDN, and it's breaking the ice on CBD1. So cannabis is not a new topic. It has been around for ages, used in the Middle East and Asia in their indigenous medicine as a botanical and herbal. It comes in many forms, and in recent years, it has been utilized more and more in healthcare. It has a stigmata that we will talk about, and hopefully, this will break that sort of hold on the stigmatism of this as seen as an illicit drug. So I hope you enjoy this presentation. This lecture is not intended for medical advice. This is for informational use only, and I will have some disclosures to discuss. First of all, my financial disclosures. I own Carolina Holistic Medicine. I also am founder of the Priority Health Healing Academy, a 508c1a nonprofit. I am a senior fellow in the formal FLCCC, now known as the IMA, which is a advocacy group for patient safety, especially amongst vaccines. I'm also on the educational committee and advisor to the Body Healthcare. I also sit on the medical advisory board for the LDN Research Trust, and I am not involved in any pharmaceutical and nutraceutical companies, so I do not have any conflicts of interest. I also like to talk about my evidence-based medicine disclosures. Again, I've been disenchanted with a lot of what we've come to know in the last few years about irregularities in our powerful, high-power journals like JAMA, New England Journal, British Medical Journal. So I have now, in the last few years, have given a EBM disclosure stating that I will list references, but everyone needs to do their due diligence as far as what they are truly saying, if they've been captured, and if the research that is published is actually truthful. For those in the audience that are actually interested in learning a little bit about why I have formulated this opinion, I have 6 references here. These are all links to interviews of retired editors and chief editors of some of the journals on what they have to say about the truthfulness in what has been published in their journals. The objectives of this lecture are to understand cannabinoids and the ECS system, the endocannabinoid system, the proper use of CBD and other cannabinoids, and how Delta 8 fits in to all this, and how we can comfortably and appropriately pair up CBD and low-dose naltrexone. We'll talk about chrono-pharmacology, the impact of dosing and timing. And then I'll discuss 3 cases where we're using LDN and cannabinoids together. Cannabinoids are pretty complicated. There are many of them, about 100 to 150 in the family of cannabinoids and their respective receptors called CB1. So this is a graphic depiction of the different cannabinoids seen, and sometimes they also appear in products with terpenes that enhance their effect. We'll discuss that as well. There are some questions to be answered. What is the history and role of various components of cannabis, including THC and CBD? There's CBN, CBG. There are a lot of others designated, other cannabinoids, in medicine, and how does research into the impact of endocannabinoid system pave the way for further exploration in this field? What is the entourage effect, and how does the combining effect of different cannabinoids and terpenes found in cannabis, particularly their anti-inflammatory, antidepressant, neuroprotective, antimicrobial, sedative effects, and indicate a vast potential of cannabinoids in healthcare? Why is the understanding and measured cannabinoid tone, which is impacting pain thresholds, digestion, mood, sleep, and even has a place in cancer therapies, how this is important and how it can relate to some genetic testing of symptomatology and tracking its use as an asset. What is the significance of working with knowledgeable practitioners with medicinal cannabis and cannabinoids? Let's first start by defining the endocannabinoid system, or ECS. The endocannabinoid system is a biological system that regulates various functions in the body, involving CB1 and CB2 receptor systems, complex cell signaling networks involving cannabinoid substances, enzymes, and cannabinoid receptors that regulate functions in the human body. If you look at CB1, it involves the nervous system or central nervous system. CB2 involves the immune system and peripheral tissue cells. First discovered in 1990s by Dr. Lisa Matsuda while at MUSC in Charleston, South Carolina. That's my current hometown, and MUSC is the Medical University of South Carolina, who described the structure and the function of the cannabinoid receptor CB1. And then there's Dr. Heinous and Dr. Devane, discovered the endocannabinoid anandamide and neurotransmitters that bind to CB1. The ECS consists of cannabinoid receptors, endocannabinoids, and enzymes that stabilize and degrade or break them down. Further research by Dr. Russo and others, and books by Dr. Russo and his research further continued the feverish pace to understand this system. So the cannabinoid system has been with us for millennia. The dawn of creation of our human species, minor cannabinoids sought for the top three things: pain, sleep, and mood. Endogenous, they have anandamide and something called 2-AG. Short only for a short time do they last, rather few compared to plant-derived cannabinoids. So you have the endogenous that are short-lived and pretty mild by comparison. Exogenous, you have plant-derived. There are very many. They last longer, and there are several forms of delivery via oral, inhaled, topical, transdermal, and even now IV. They are referred to as phytocannabinoids. This depiction looks at endocannabinoid system in a graphic representation of CB1 and CB2. Endocannabinoid systems begin evolving about 600 million years ago, but only was recently discovered in the 1990s. The endocannabinoid system is the largest neurotransmitter system in the human body and plays a critical role in how our body can benefit from CBD, CBC, and other hemp products. Cannabinoids are not just a one-shot product that's found in plants. There's about 150 identified isolates of cannabinoids that are known and have been discovered thus far. Examples are CBD, probably one of the most commonly recognized. There's CBN, CBG, CBC, CBL, and they all have different properties and benefits in health. There's also Delta 8, which is sort of a synthetic version of Delta 9 and THC. There's something else called THCV. So CBC has antiviral, antimicrobial effects. It stimulates the bone, it's antioxidant, and helps with neuroregeneration. CBG has antifungal, antipsoritic, and affects muscles and bones in recovery, and also is an antioxidant. CBN has a sedative effect, lowers inflammation and seizure activity, as well as helps induce sleep and takes on anxiety. CBD, or CBD little a, helps with mood, sleep, pain. It's used topically for dermatological issues like skin conditions and acne. And CBDA is twice better absorbed than CBD. CBL has anti-inflammatory, anti-cancer, and antimicrobial products. They are found in plants and fungi. The mechanism of action of these, they are hydrophobic in nature. The cannabinoid substances suggest that cannabinoids resemble anesthetic agents like drugs of anesthesia in their action. They non-specifically disrupt cellular membranes. Recent evidence supports the mechanism involving a G protein coupled receptor, or G receptors, found in brain and neural tissue. They are known to inhibit adrenal silase activity, and it is also very dose dependent and stereoselective. With the great and fascinating complexity of endocannabinoid systems, as well as its relationship with exogenous cannabinoids, several types of receptors and systems in such a wide and varied distribution in the body, give us the challenge of exploring and researching the benefits for humanity of this type of system. So this is a representation of the neurons and the synapses in a negative feedback loop in this depiction. The endocannabinoids, the anandamides, the 2-AG, and your phytocannabinoids, THC and CBD, are all represented here in this system. So you have endogenous and exogenous members of this elaborate system. THCV, tetrahydrocannabinol variants, is a compound in cannabis that offers a unique array of effects and medical benefits that set it apart from other cannabinoids like THC and CBD. THCV is an appetite suppressant, so it might be helpful in weight loss programs. In contrast to THC, THCV may dull the appetite, so you don't get those munchies associated with THC and marijuana use. This may be good for consumers focused on weight management. THCV may help with diabetes, may be able to regulate blood sugar levels and reduce insulin resistance. THCV may reduce panic attacks. It can mitigate anxiety attacks in those suffering from PTSD without suppressing emotion, like some pharmaceuticals do. THCV may help with Alzheimer's disease, tremors, motor control, and brain lesions associated with Alzheimer's disease, and they appear to improve by the use of THCV. And there is a lot of research in progress right now. THCV stimulates bone growth because it promotes the growth of new bone cells. and is looked at in those who suffer from osteopenia and osteoporosis. THCV binds to the CB1 receptor with an affinity of about 30 times that of THC. Often referred to as endocannabinoid tone, balance or tone between endocannabinoids. You may have too much tone or you may have too little. So idiosyncratic outcomes, effects versus side effects has been noted. Avoid the hype. It is just another herb or botanical within our armamentary. So I don't like to think of cannabinoids or cannabis as anything special or to be hyped up, as we use this as we use any other herb in our formulary. Let's talk for a few minutes about the entourage effect, the combination of cannabinoids that work together in a symbiotic relationship have what we call the entourage effect when they produce a heightened effect. So for example, CBD plus THC allows for 10 times the effect of one or each used by itself. Using CBD in combination with some other agents is more effective in dental pain, as some studies point out. So you have full spectrum and then you have your isolates. So sometimes full spectrum works a little bit better than each isolate independently. Here are some examples of combination specifically designed cannabinoids for help with inflammation and for insomnia or restlessness, anxiety. They're combining cannabinoids with terpenes in this case, as depicted on the left. And on the right, we have a product that is a CBD for IV infusion. Can given in microdosing or in large doses depending on what you're using it for. But it comes, again, in oral forms. Inhalation we kind of frown upon because of issues with damaging the lung tissue by inhaling, or vaping, but then actually IV is a newer delivery system recently introduced into the market. Testing your DNA for how cannabinoids can affect you. So DNA testing to figure out the best cannabinoid for you is now available. You can upload data sets or zip files from 23andMe or Ancestry.com. And then there's 57 different genetic trait reports in 12 different categories. So you'd upload your zip file to explore this DNA testing. Precision cannabinoid ratios and terpene profiles are then matched. And then this is a way to personalize drug-to-drug interaction alerts, and also cannabinoids risk-benefit ratios can also be specified via genotype. Is this fluff? Should I get it done? That is totally up to you. I've known about this technology for quite a while, but I have yet to order it on a single patient thus far. I need more data on its efficacy and usefulness before I go and just carte blanche test all my patients. Terpenes and cannabinoids. They're a pretty good combination because they embellish each other. Terpenes are used with some coming from different plant material, and they each have their own sort of benefit for calm or for pain or for topical use in skin conditions, for sleep and calm, wellness, for preventative, also for focus with brain function, and for sleep. So terpenes are a very large group of aromatic volatiles or fragrances, unsaturated hydrocarbons found in the essential oils of plants. Like typically you see them in conifers and citrus trees, but also rosemary, lavender, and cannabis itself. They work synergistically with cannabinoids for better effects, and you can sort of laser target certain conditions by using a combination of cannabinoids with their respective terpenes. This is a very broad subject, and I can't, in just an hour, discuss all the nuances of this. But it's the benefits of full spectrum hemp oils versus isolates are also part of this discussion. And they help cannabinoids along the way with extra benefits. Medicinal marijuana is gaining traction in this country. It unfortunately has a stigma of being used just for recreational purposes only, and because the United States made it illegal, and that sort of had an impact in a very negative way on the use of this medicinally. However, in indigenous medicine in the North and Central and South America, this was used pretty commonplace as a medicinal agent, just like anything else, just like rosemary, just like lavender, just like cat's claw. So it's quite unfortunate that this is, for many years, has been pulled out of the kind of formulary of useful herbals and botanicals. Well, let's talk a little bit about the stigma associated with cannabis and cannabinoids. 50 years of being associated with stoners and hippies of the 70s. Negative impression with weed, ganja, MJ, chronic. Terms like this don't help at all. Like alcohol during Prohibition era, we see cannabis and marijuana as something illicit and frowned upon. But just like alcohol during Prohibition, that amendment was overturned. Medicinal herbs going back thousands of years to first documented use in Tibet. Use of cannabis goes back to Neolithic years, 8,800 BCE. So it's longer than even recorded history. The earliest restrictions on cannabis date back to the Islamic world of the 14th century, when it was frowned upon for its hypnotic effect on people who used to imbibe. One of the earliest crops cultivated in ancient Korea was very important as a cash crop back 3000 BCE. Well, if there's a profit to be made, pharma kind of jumps in. So a few years ago, Jazz Pharmaceuticals had a cannabinol Schedule 5 called Epidiolex. Very, very expensive, but you know what? It garnered FDA approval. So it was used as an oral agent to treat seizures associated with Lennox-Gastaut syndrome, LGS, and other syndromes in patients 2 years and older. Two of the most difficult to treat epileptic related conditions. Hey, didn't Charlotte's Web CBD company have success with that? And they made a documentary over it. So my question is, why overpay for the same sort of agent just because it comes out of a pharmaceutical company? I don't think I would. Here's an example of a commercially available company, pretty large company out of, I believe, Kentucky. They grow and process their own hemp oils, and this is an example of a full spectrum hemp extract. You see that it's in quantity of 60, and it's in soft gels. And each soft gel has 15 milligrams of cannabinoids. So this is just one of several examples. I'm not promoting any particular product. Here's yet another set of examples of full spectrum hemp. This is one that offers CBD, CBG, and Delta 8. It's some product by the name of Trifecta, which has all those three different cannabinoids, and it is amazing for anxiety and sleep. You have to adjust the dose individually. Sometimes it only takes 1 to 4 drops on the tongue at bedtime. Others require a full dropperful or even 2 dropperfuls for effect. It comes in liquid tinctures, it comes in gummies, and also um, this is something that's grown locally in South Carolina in Hartsville. And I know the CEO, it's a great product, very clean, and they work with the local enforcement agencies as well as Clemson University on their product. So we're going to talk about low-dose naltrexone and cannabinoids. It's a good pairing. And the pairing of LDN with other agents is just very smart. You can pair it with many agents. Amloxanox is one. And I'm going to talk and focus on cannabinoids in this talk. And you have advantages for your cancer patients, both as an anti-cancer and also to relieve anxiety and pain. Advantages in pain management have increased levels of pain control when you combine those two together. Advantages in anxiety and mental health issues like depression, both are useful by themselves and even better in combination. Advantages for insomnia. If you have an LDN patient who is intolerant at nighttime dosing, move the LDN to the morning because sometimes the vivid dreams are uncomfortable. And in about less than 10%, I would have to say, there are some sleep disturbances with LDN. So it's also not for everybody, but if you move the dosing to the morning, it mitigates some of those nighttime issues. And then when you combined it with nighttime use of cannabinoids, the chrono-pharmacology of timing LDN first, cannabinoids second, is fulfilled, and it has a better track record in cancer recurrence. In other words, it reduces the number of recurrent cancers when you use that particular timing. So there's some good chronopharmacology involved. Immune health and autoimmunity is very well documented, especially LDN is like the magic bullet for autoimmune diseases. And you can also pair up both LDN and cannabinoids and both together with DMSO delivery for topical use. So you place these agents in some DMSO and then you can apply it to an area that's inflamed or painful, like a joint. The last comment I made, applying DMSO with LDN and cannabinoids over a joint, I hope everyone understood I meant a joint like a musculoskeletal joint, not the kind of joint you would smoke. Okay, all kidding aside, the MOA of each benefits and pairing them together, they work synergistically and usually much better. Possible senolytic properties, the overlap of benefits is like 1 plus 1 equals 4, not just 2. So it's an exponential increase in benefit. The multitude of delivery systems, we're talking oral, topical, oral plus IV. It can be inhaled, but we don't really do that much in our center just because inhalation may cause some harmful effects with other things that are in the cannabis and the cannabinoids if you're using those oils in a vape machine. Not particularly um, interested in doing that with potential harm to the lung tissue. Like I mentioned previously, there's chronopharmacology. The timing is everything. So timing of LDN is a science and art in itself, whether you once a day dose it, is it morning, evenings, before bed, is it BID or twice a day dosing, even TID, and we have some practitioners that do QID dosing for some psychiatric illnesses. So can cannabinoids and cannabis be dosed a special way. Dosing is everything. Timing is even more important. So do you put the LDN first, followed by cannabinoids, vice versa? There's some studies that show LDN first, cannabinoids second by 2 or more hours later. Also split dosing of LDN, utilizing Very low dose naltrexone and ultra low dose naltrexone is also beneficial, but it has to be customized and personalized for each patient. It's not a one size fits all and you can't cookbook it. So I always, when I have to do both, I'll use my LDN first, followed by my cannabinoids. And the lesson from a cancer recurrence study with proper dosing schedule is listed in our references. Okay, now we'll talk about a few case studies. And so our first case study will be discussing LDN and cannabinoids for pain management. So we're opening with a 42-year-old female with chronic conditions like MSIDS, that's multiple system infectious disease syndrome, joint pains, and hormone imbalance. Was on subpar over-the-counter CBD oil from a local quick market, so not a very good brand or quality CBD. Unaddressed the underlying medical conditions that were realized, and in treatment of her chronic MSIDS or chronic Lyme disease was undergoing. Herxing became uncomfortable. The herxing is short for Herxheimer or Jerash-Herxheimer reaction, which is a die-off reaction in the treatment process of her chronic Lyme disease. Also resulted in some insomnia and chronic migratory pains. LDN was okay with the Q-day dosing, and the original CBD was ineffective. So what we did is we increased her LDN to a BID dosing at the current dose, and then we used a high-grade CBD, a product called Trifecta, which also includes Delta 8, and that was the answer. It was able to mitigate her condition of chronic pain and migratory pain and even insomnia. In this case, our second case study is a male patient. Again, we're using low-dose naltrexone with cannabinoids for insomnia. This 30-year-old male patient with a history of chronic insomnia, not mitigated very well with a lot of different interventions. He also suffered from autoimmune disorders. LDN was started dosing in the PM and proper titration up to a therapeutic dose. Insomnia worsened on LDN and was unresolved by switching to morning dosing. Apparently, he was intolerant of low-dose naltrexone and it caused a sleep disturbance, which we see probably in less than 10% of patients. The advantage of LDN on autoimmune was difficult to walk away from. So LDN dose remained in the morning and dosing dropped from 4.5 milligrams to 2 milligrams for better tolerance. The cannabinoid CBD was added to the evening to address insomnia and worked very well. So here we see moving the LDN dose to the morning to mitigate issues with intolerance due to sleep disturbance, and then using a high-grade CBD CBG delta 8 agent to resolve his insomnia. And this combination worked very well for this individual. This third case I'm presenting is a 63-year-old gentleman with a high-grade prostate cancer. Again, we're using low-dose naltrexone and cannabinoids for cancer. LDN was started and proper titration to help with cancer and with pain. The aggressive nature of the cancer resulted in bone metastasis and lesions, which caused him great pain. The advantage of LDN as part of an anti-cancer treatment regimen is well documented, and in this case was applied. LDN was dosed at BID dosing and followed by CBD oil administration. Cannabinoids, CBD, was added 2 hours post LDN dosing for more effectiveness. As studies show a reduction in cancer recurrence in dosing this way. In other words, LDN first, CBD second. Unsure of outcome and condition as patient was lost to follow-up. So here we have a case of LDN and CBD in cancer where evidence-based medicine backs up the use of each agent by itself and in combination. This should be considered for folks with high-grade cancers. Again, this is an example of chrono-pharmacology. I'm now going to list my references from peer-reviewed journals and other sources to back up what I've said in this lecture. Please be aware of my evidence-based medicine declarations and disclosures, but here they are for your perusal. You can stop or pause this program and take a look at each of these more carefully. And that wraps up this lecture on cannabinoids in conjunction with low-dose naltrexone. If you need to reach me, I do accept emails with questions. Just reference this lecture in the subject line, dr.saleeby@carolinaholisticmedicine.com is my professional email address. Our website for our clinic is carolinaholisticmedicine.com. For the educational arm and the Priority Health Academy, you can reach us at priority-health.us for our educational programs. Thank you for your attention today.